the studies we've had previously show that exercise works to increase the tolerance of cancer treatments. So people who do regular exercise, and again, it's walking, 30 minutes a day, 6 hours a week, can increase the ability to have fewer side effects and complete chemotherapy for early stage cancers or metastatic cancers.
Hi everyone, I'm Samira, the founder and CEO of Manta Cares. I'm a breast cancer survivor and the host of the podcast, The Patient from Hell. This episode is kind of special for us. It's our first one that we're doing a live recording while at ASCO. It's Monday morning here. This is the Monday after 3 full days of listening to clinicians and researchers share the latest and greatest on clinical trials, research, insights coming from the cancer community. There are 3 very exciting themes that we're going to unpack in this episode. Theme number 1 is on the advent of SERDs in the early stage breast cancer space. The second is, of course, AI. We have to do that. And then number 3, which probably is the one I'm most excited about, is finally we have actual data that shows that exercising actually has a tangible benefit on your survival as a colon cancer patient. So take a listen. And we have a very special guest. You've heard him before, Dr. Doug Blayney. So Dr. Blayney, who is a former ASCO president, he has 45 years of experience treating patients. Along the way, he ran Stanford's Cancer Center. He's also the chief medical officer at Manta Cares. So he's going to be the guest on the show summarizing what he has learned over the last 3 days, specifically for patients, care partners, and survivors who are going to be listening in. We have an incredibly special one today because we're recording at ASCO with Dr. Blayney, who used to run ASCO, amongst many other things. How are you feeling?
I'm feeling exhausted. It's an invigorating meeting. It's great to meet other people, and especially this year there were a lot of advocates who I think had input, at least into the program. They did have input into the program. They also paid attention and made oncologists reminded us treating docs that there are people that we deal with every day whose lives we're supposed to be making better who are watching this. So that is positive, I think, in many ways.
I clearly, unbiasedly agree with that statement.
Okay.
So, Dr. Blayney, let's start with the top 3 things that you think have been themes of the last 3 days.
So the main one thing that is important in my view is the de-escalation of some of the chemotherapy and other toxic cancer treatments we've used for the last 20 or 30, 40 years. Antibody drug conjugates, which deliver chemotherapy to a targeted cell and have minimal or few systemic side effects, are moving closer and closer to early treatments of breast cancer, pancreas cancer, lung cancer, and gastrointestinal cancer. So I think that's an important thing. Secondly, we as a profession of cancer doctors and treatment teams, just like every other profession, is struggling with how do we work with artificial intelligence or AI. Both the major professional societies that I deal with as an oncologist, ASCO and NCCN, are figuring out how to use AI to make their guidelines more accessible to patients. Finally, the third theme I think is important is what can you do for yourself? Not yourself, you, but what can the patient do for themselves to reduce the burden of cancer, increase survival. An important study came from Canada this year showing that an exercise program, and it wasn't, as I say, NFL National Football League
Thank you.
Training camp type exercise, but walking. A randomized study of almost 1,000 patients with colon cancer, with potentially curable colon cancer, showed that patients who are assigned to standard of care, meaning giving a piece of paper, you need to exercise, compared with patients who are randomized to have a coaching session every 2 weeks for a year, and then then monthly after that, had better survival, significantly better survival, and significantly less recurrence of cancer. So that's something people can do for themselves. Walking,
Yes.
again, walking, it's not marathon running and that sort of thing. And also we're learning about obesity after smoking and alcohol cessation. Obesity is a major contributor to cancer mortality. So reducing obesity and the roles of GLP-1, some of the drugs, Wegovy and Ozempic, are being sorted out.
The three themes from your perspective. Theme one, de-escalation of chemotherapy into some of the more novel agents like ADCs.
Antibody drug conjugates.
Antibody drug conjugates. I feel very smart that I know the acronym.
Yes.
Theme number two is the advent of AI, in particular in the roles of associations and guidelines.
Yes.
Theme number three is what can patients and survivors do for themselves. And key amongst those are exercise, i.e. walking, yes, and management of obesity.
Yes, I agree.
Incredible. Can we start with the third one?
Yes, certainly.
Clearly an area of interest for me. My question for you is, we've known that. We've had studies come out talking about the role of walking. Why is it? What's different?
Well, the studies we've had previously show that exercise works to increase the tolerance of cancer treatments. So people who do regular exercise, and again, it's walking. It's walking, 30 minutes or maybe 6 hours a week, 30 minutes a day, 6 hours a week, can increase the ability to have fewer side effects and complete chemotherapy for early stage cancers or metastatic cancers. This was the first study, again, randomized, so half the people got standard care, which is, here's a piece of paper, you should exercise more, compared with people who had a coaching session. And it turns out this was, I think this was in-person coaching.
Oh, wow.
It remains to be seen whether virtual coaching has the same benefit, or, gee whiz, can your partner encourage one into doing more exercise? So it seemed to be the exercise plus the benefit of positive reinforcement from a coach every so often that seemed to have the benefit. It wasn't curative, but it was about a 30% benefit in terms of survival in addition to chemotherapy for early stage colon cancer.
That's pretty cool.
It is. And I read one commentator said if this was a drug, it would be approved right away.
And might be a blockbuster if you think about the economics there.
Yeah. So again, it's something that I think people are tumbling to and again can do for themselves. This reminder, this was in colon cancer. My bet is that in other potentially curative settings like breast cancer, like early stage lung cancer, and some of the other solid tumors, and maybe even lymphoma and other tumors, the same benefit is likely to hold. We don't know why it is. There's been early work in the GLP-1, as I mentioned earlier, drugs. They look to have benefits that may be independent of weight loss, but that's being sorted out as well.
So, in the world of AI, we have all the AI stuff happening, and then you have this study come out. And as a survivor, it makes me so, so happy that we have studies like the exercise one happening.
It's pretty pedestrian.
It is. It really is. It
you
really
get a
is.
pedestrian.
Oh, sorry. I was slow. Oh, my God. I get it now. Now I get it. Delayed effects.
Yes, right.
For some of you, you may know, we, in addition to the podcast, have a free digital platform for patients and families. And we build what we call maps. I'm showing you a paper version, guys, but it's digital. But the reason I talk about maps is our maps are disease specific. We have maps for early stage breast cancer, the different types, metastatic breast cancer, and metastatic non-small cell lung cancer. One of the benefits of the community is that we keep these maps updated. So the reason, one of the many reasons we're at ASCO is to make sure we're listening to the changes that are happening. And post ASCO, Dr. Blayney and our incredible team of medical experts are going to be updating our map. So Dr. Blayney, we'll go map by map. Sorry, I know, lots of work. But I'd love for you to give us a sense of what's changing.
Okay.
Maybe we start with early stage breast cancer, then metastatic breast and metastatic lung.
Yeah. So remember, we've taken the position that the maps reflect FDA-approved drugs in the United States.
Yes.
So many, I think the biggest change is in estrogen receptor positive cancers, there are selective estrogen degraders. Selective estrogen receptor degraders, or SERDs. Those are, there's one approved in the United States, and that's fulvestrant, which is a nuisance because it has to be given intramuscular, and nobody would volunteer for that if they could. So there are now oral SERDs coming. None of them are available in this country yet, or rather there's one available in this country. So we'll have to see how that sorts out. In the early stage hormone-positive cancers, there are. We'll have to see where the antibody drug conjugates fit in. There was a study presented comparing essentially chemotherapy-free treatment, or in other words, not free chemotherapy, but chemotherapy, so no chemotherapy compared with antibody drug conjugates and pembrolizumab, which is an IO or an immunotherapy. So we're going to have to rejigger our map to early stage map to account for some of those changes. So again, convenience for patients, less chemotherapy and oral SERDs, and also some of the, so those are the things in the early stage.
Can we clarify two things for patients watching? So SERDs is one of many types of anti-estrogen treatment.
Yes.
So there's SERDs, there's SERMs.
Yes.
There's AIs.
Yes.
And there is one more thing that I'm forgetting now.
I think that's it.
That's it.
Okay. So SERDs. Let's start from the beginning.
Yes.
Tamoxifen is a SERM, a selective estrogen receptor modulator. So it locks up with the estrogen receptor and keeps it from functioning. Next in sequence, the development are AIs, so aromatase inhibitor. So men and women make estrogen in breast cells, fat cells, and in premenopausal women, they make it in their ovaries. The AIs turn off that estrogen manufacture in breast tissue and in fat tissue. So they were originally used in post-menopausal women whose ovaries don't work anymore. Along with ovarian suppression, drugs that suppress the ovaries, AIs are used. SERDs are selective estrogen receptor degraders. So they not only lock onto the estrogen receptor, but they dissolve it or chemically make it go away.
Cool.
Permanently. So that's the SERD. Up until now, as we mentioned, it had to be given. By injection, and again, most women, I've never had one, but most women tell me it's painful.
Yes. And annoying.
Yes, and annoying. But anyway, so now the oral SERDs, what degraders, are coming along, and I think are going to be much more convenient for patients. In the early stage breast cancer treatment, CD46K inhibitors are often used with high risk, meaning high risk of recurrent breast cancers. We're sorting out who those people are. There are three, palbociclib, ribociclib, and abemaciclib. Two of them are used for adjuvant treatment or early stage. We're sorting out how those are going to be used, and potentially are they interchangeable? If somebody has bad side effects from one, can they get to another? So that remains to be seen, and that I think is something, our MAP, we've tried to incorporate coaching to patients. Doc, is it okay if I switch here?
Yes.
We think it's okay to switch, but again, it's something that patients and our viewers should be aware of.
All right, so that's early stage. Metastatic.
Metastatic, again, moving away from chemotherapy, moving away from cytotoxic chemotherapy, which has a lot of bad connotations. Very effective, but has some bad connotations. So two things came up first of all, let's address chemotherapy. Paclitaxel or Taxol is a very effective chemotherapy, often used as a first chemotherapy in metastatic disease. There's a compound, an oral Taxol, that was presented. It's been available in Korea. It's been used in gastric cancer in Korea.
Wow.
There was a study comparing oral, twice daily oral pills of Taxol or paclitaxel compared with weekly paclitaxel. Same result, same side effects. So likely this may be approved in this country. Again, we'll have to sort out with the FDA whether the FDA will approve studies that were only done ex-US or outside the US. But I think if that oral paclitaxel gets approved, that's likely to be a benefit for patients with metastatic cancer.
Wow.
Metastatic breast cancer and other cancers where Taxol is used, including lung cancer, as it turns out. So that's one in metastatic cancer. The other is the emergence of two other things to talk about quickly. One is the movement of antibody-drug conjugates and the combination of antibody-drug conjugates with IO or immunotherapies. Remember, antibody-drug conjugates are a way of delivering chemotherapy targeted to a cancer cell and sparing, hopefully, other normal cells like hair cells and the cells in the GI tract and the bone marrow. So that, again, moves away from chemoptherapy, from systemic cytotoxic chemotherapy. And finally, there's the emergence, and we're starting to understand about ctDNA use. So ctDNA, circulating tumor DNA. So remember, DNA is the building, the genetic material that tells normal cells and cancer cells how to grow. In cancer, there are mutations in the DNA that either turn off switches that say stop growing. So when that DNA is mutated, that off switch is flipped to on and the cell grows. And there are also cells that turn on switches that are normally off. So anyway, the DNA in the cancer cell, when the cancer cell dies, the DNA is shed into the blood, and you can detect it in the peripheral blood. now it's often used again for in pregnant women to tell about birth defects, because the baby's DNA is shed into the women's blood. That's where this
It came from there, didn't it?
That's where this technology emerged. It was noticed that cancer cells, when they die, they shed DNA, and that is a way of perhaps detecting cancers before they're apparent. But just because the DNA is abnormal doesn't mean the cell can propagate, because there are other steps that happen. So it's probably not ready for prime time screening for cancer in normal people. However, in people with known cancer, one can take a biopsy of the cell of the cancer.
Yes.
Measure the DNA, look for the aberration, for the abnormality, and then in the blood, as time goes by, that DNA particular mutation can be looked for as a sign that the cancer's back. There was a study that showed that ctDNA monitoring can detect cancer recurrence earlier than imaging, CT scans, PET scans than we do now. Well, that's okay, so what? But this study showed that if you detect it earlier and switch treatments, it can lead to prolonged survival. Previous studies that have detected early recurrence have failed because the therapies weren't any good. Now we have better therapies that can help, that can be applied earlier in the treatment, and I think kill the cancer when it's smaller, because any therapy works better in a smaller cancer than a bigger cancer. So now that we have more effective therapies, monitoring with ctDNA, detecting recurrence earlier, can be a benefit to patients.
Dr. Blayney, just to make sure I understand this study was run in the metastatic setting.
Yes. First line, so first treatment.
First treatment. So when we talk about recurrence and how this technology is helping with early detection of recurrence, but it's in the metastatic setting,
right.
Don't those patients already have
They already have cancer, yes. So a good thing is that many of our first-line treatments are very effective, so that they make the recurrence either get much smaller or disappear. Rather than monitoring for when the cancer starts growing again with CAT scans or PET scans or symptoms or something like that, the ctDNA monitoring I think, is going to be shown to detect recurrences when they're smaller. And now we have more effective treatments. We can move in those more effective treatments earlier. And this was the first study that showed a more effective treatment applied earlier can actually improve survival.
Fascinating. Can I just play that out from a patient perspective?
Yes.
Okay, so if I'm a metastatic breast cancer patient, I go in, I get first-line treatment.
Yes.
The first-line treatment is effective.
Yes. And you've had your tumor biopsy had DNA testing.
And my tumor biopsy had DNA testing when I pre-treatment.
Yes.
Because it has to be, okay, got it. So pre-treatment, I get my biopsy done. At that point, the DNA is tested.
Yes, and stored
somewhere, which is a whole thing we won't touch. Okay. And then after that, I get treatment. My treatment is effective. My tumor goes away effectively.
Yeah, or gets smaller.
I'll get smaller. So today's standard of care, the way I am being monitored is usually imaging. Yes. Imaging meaning some combination of mammo plus ultrasound.
Well, maybe not mammo, because the cancer may be in your bone or in the liver, lungs, etc. By X-ray imaging of some sort.
Some sort of imaging. And instead of imaging, or in addition to imaging, we have the liquid biopsy.
Yeah, the ctDNA liquid biopsy, yes. Cute term. Okay.
Cute term. The ctDNA test that allows me to essentially do a blood test effectively.
A blood test, yes.
And with that blood test, the advantage I as a patient get is that I am able to more conveniently monitor for signs of recurrence, potential recurrence, right? Because
Yes.
I would most likely have to do imaging anyway after that, or no?
Tomorrow in the clinic, yes, imaging. But the key thing that's this part of it is that the mutation is known in your cancer.
I see.
So the blood test looks for that specific mutation. It doesn't look for all mutations. It looks for those specific mutations. Usually there's, half a dozen or a dozen or so. And when those mutations start appearing in the blood test, that's a sign that oh gee whiz, we need to make a decision about changing treatment. Heretofore with biomarkers, so this is really a biomarker, with biomarkers like CEA or CA15-3 that have been used, or circulating tumor cells that have been used, yes, they can detect recurrences early, but the treatments have not been effective in order to make a difference in long-term survival.
Wow. Okay.
And so this, if it's borne out, and I think it probably will be important. We know that in colon cancer, for instance, in early stage colon cancer, if after adjuvant treatment, there's no circulating tumor DNA or the liquid biopsy is negative, those patients have a much better prognosis. But in colon cancer, the treatment for recurrence, the variety of treatments are not as numerous as there are in breast cancer. So colon cancer, yes, you can detect a treatment early. You can detect a recurrence early, but the treatment application hasn't resulted in a survival benefit. Breast cancer, that's a distinction, which I think is going to be borne out. And as treatments get better, it'll be less, radiation, probably less expense, less trouble, less, again, a de-escalation of monitoring for recurrences.
For my friends in the metastatic community, that feels pretty big.
Yeah, I think so.
Okay, metastatic lung, not small cell.
Yeah, not again. I think I'm not as much of a expert in metastatic lung cancer, but I think where we're going is for more and more benefits of the IO inhibitors like pembrolizumab and those sorts of things. Again, there's some de-escalation strategies that are playing out in lung cancer, and I think we'll also see the circulating tumor DNA monitoring as
Dr.
well.
Blayney, can you remind us what an IO is?
IO is immune checkpoint inhibitor. So, simple way of thinking about it takes when somebody develops cancer, their immune system has a break on it that seems to not recognize the cancer as foreign. So if we were to transplant a kidney into somebody from another person, the donor, that the body's normal immune system would recognize that kidney as foreign and try and reject that kidney, heart, liver, other transplanted things. So the IO, for various reasons, a cancer, as it develops, the immune system becomes accustomed to it and has some brakes on it. And that's the defect that cancer unfortunately has. So the body's immune system doesn't recognize it as foreign, and there's a brake on the immune system, just like a brake on a car. Yeah. The IO, the immune checkpoint inhibitor treatments, remove that brake. So the body now is free, if you will, to recognize that cancer as foreign and try and reject it, just like it would a transplanted kidney or other organ.
Wow. Okay.
Now, it also it's fair to say that sometimes other normal tissue gets recognized as foreign. So there's some side effects, including the damage to the thyroid, damage to the colon, damage to the lungs that have to be carefully monitored for these toxicities.
Thank you so much.
Okay.
I'm going to start wrapping us up because that was quite a bit for
and it's
3 days.
Yes.
And we haven't even, I think we just skimmed the surface.
Yes,
Is that fair?
I think, as time goes by and other reports emerge, that our viewers can dig deeper into what's going on, and with the help of their doctors. But I think our maps and our platform can coach our users, community, to ask their doctors about many of these things.
Do you know what I'm sitting in right now?
A chair.
Oh, thank you. Your grandpa jokes are getting on point, Doc. The thing because we've done these recaps now for 3 years, 2 years, 3, this is our third one.
Okay.
And then we've done one for SABCS.
Yes.
And the theme I'm seeing, at least for some of the topics we've discussed today, is convenience being a differentiator for different drugs coming to market.
Yes. Convenience, because for good reasons, people are going to be on these drugs for a while. So come on, doc, let me get on with my life.
Yes.
I can't show up every week
Yes.
to get a 4-hour infusion.
Yes.
I need to get on with my life.
I think that's true. And I think in the patient community, I think there's a lot of burden, right? Both logistical, time to the point you're making, and of course financial, that is put on the patient inadvertently. And historically, at least I have not seen that being necessarily the differentiator. Taxol to oral Taxol feels mind-boggling to me. I mean, I had these 6 infusions of Taxol, and to even think that I might be able to take a drug feels kind of foreign. So I'm seeing that kind of across the board as a unifying.
It wasn't announced this meeting, but Herceptin and Perjeta are also available by subcutaneous, so you don't have to show up every 3 weeks to get an infusion.
That would be very nice. I would have liked that.
and some of the other immune checkpoint inhibitors, which are given by IV infusion, are now available subcutaneous for sustained release. So again, continuing on that theme of convenience without sacrificing benefit or anti-tumor effect.
Yes.
As you alluded to, everybody's going to be struggling with the financial toxicity.
Yes.
And we'll have to figure out a way around that. I think, one of the things about this meeting is there's a lot of drugs coming to market. Competition is a good thing to drive down price and also to switch up for side effects. So
Yes.
I think that's important as well.
I agree. So you're sitting here wearing 2 pins, 2 amongst a few
Great.
that I believe you have in your bag.
Yes.
But I know one of them, but the other one,
So
let's talk
ASCO,
about that.
American Society of Clinical Oncology, which may be more appropriately named the International or Worldwide Society of Clinical Oncology. It's been going for 50 years now, and this is the premier meeting. It's huge, as many of us have found out, but it's it has set the standard for cancer meetings. Many of the smaller meetings that are disease focused also look for new things coming out of them as well. But this is a great one for cross-pollination, because what the colon cancer people are doing can translate into the breast cancer
Yes.
community, as we talked about.
Well, thank you so much for taking the time. Thank you for summarizing it. I know for a fact that patients and families appreciate that we summarize these fairly large congresses, and in particular, they appreciate you taking the time to explain things that are happening to us. So,
Well, you make it easy.
I try. Hence the name of the podcast.
All right.
Thank you so much, Dr. Blayney.
All right. Thanks. And thanks. Goodbye.
This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Manta Cares Inc. or Manta Cares' sponsors.